we do during the third trimester, we need to assess the fetus. Remember, and you'll learn when we talk about fetal assessment, we can't successfully assess the fetus until the third trimester because they're just not mature enough to do testing that is reliable. So if they're in the third trimester, we'll do maternal and fetal assessment. Activity restriction, the first thing we do with mom is we put her on bed rest or modified bed rest. Do y'all know what modified bed rest is? Bed rest with bathroom privileges, basically. Up for meals, up to the bathroom. They can sit up to eat, they can sit up to go to the bathroom. Other than that, they should be in the bed or on the couch or on their left side. So obviously they have to quit working. Physician dependent, oftentimes they'll give them a diet low in sodium. Again, that's physician dependent. Some docs say that's hogwash, some docs say it works. So, they may or may not do that. So that's what we'll do to start with. That's mild. So the patient goes to the doctor. She's 28 weeks. Her blood pressure is 140 over 96. She's got 1+ proteinuria and some edema. Okay, you're not going back to work. You're going to go home, bed rest with bathroom privileges. You're going to lay on your left side. You're going to relax. No stress. The reason we don't want them to stress is because the more uptight, amped up they get, it certainly increases their seizure risk. They go reflexes can get more risk, so keeping them calm and quiet is important as well. So that's what we're going to do for a mild preeclampsia. If it is severe, that's where they have the greater risk for pregnancy complications. So the balance is between managing the patient and figuring out when it's time, okay, we need to deliver the baby. We've gone as far as we can. So remember, again, if your patient's 28 weeks, the right thing to do is to see if we can get by some time. But if they're close to term, there's no use messing around with it. Get them delivered. So if it's severe, blood pressure 160 over 90 or higher, 2+, 3+, or 4+ protein in their urine, that classifies it as severe, and now we're going to put them in the hospital. We're going to admit them to the hospital. So now we have to treat that preeclampsia. Now they're at risk of seizure because they have severe preeclampsia. So if they're at risk of seizure, we got to prevent seizures. And the treatment for preventing seizures, what's on the next slide. IUGR caused by the disease might make delivery a better option. So if they're in the third trimester, we're going to look at the baby. How's the baby doing? Is there intrauterine growth restriction? Is the baby growing? Does the baby look okay or not okay? If the baby doesn't look okay, then there's no point in keeping them pregnant. If the baby's not doing well, it may be better to deliver the baby. But if the baby seems to be doing okay, we may try to buy some time. So that means we're going to put the patient on an IV infusion of magnesium sulfate. An IV infusion of magnesium sulfate. We give it for one reason, and one reason only. It is not to lower the blood pressure. That's what a lot of people think. Although that may happen just as a result of the relaxation. It's given to prevent seizures. To prevent seizures. Not to decrease the blood pressure. Prevent seizures. But if you put them on bed rest, put them on their left side, relax them, turn the lights out, their blood pressure may go down. But it wasn't, the mag sulfate didn't typically cause it. Magnesium sulfate relaxes the smooth muscles. That's how it prevents seizures. So again, if you in a similar situation, you have an alcoholic who are concerned about going in DT, coming after doing a med-surg unit where you give your alcoholic patient mag sulfate in their IV. You seen that? It's the same thing. They just don't give it nearly as high of a dose as we do. On OB, it's considered a critical drip because of the dosage and the risk factors associated with the infusion. On a med-surg floor, you usually give it at a much lower dosage, so they'll give it out on the regular floor. This is the ICU dosage, basically. So it relaxes the smooth muscles, thereby decreasing cellular excitability and subsequent risk of seizures. So when we start this mag sulfate, their reflexes should become very relaxed. It relaxes the smooth muscles. So if they had very brisk reflexes with clonus, those should go away. They should return to normal. And what may even happen is they may become below normal because of the mag sulfate. Any patient on magnesium sulfate infusion at the rate we're given needs to have mag levels every 6 hours. Because we base their dosage on what we consider therapeutic. Therapeutic level for preeclampsia is 4 to 6 milliequivalents per deciliter. 4 to 6. You do need to remember that. Darn it. I'm not a lot big on dosages and things like that, but in this case, you need to remember that. You might see a question where it asks you about therapeutics. The therapeutic mag level is 4 to 6. So we're going to base the dose on that mag level. We'll start them at a specific dose, then we'll start doing mag levels, and if they're on mag sulfate, they're going to be getting hourly vital signs, hourly urinary output, and hourly deep tendon reflexes every hour. So their mag levels will only be 6 hours, usually, but their vital signs, urinary output, every hour. Why do you think we need to do that? Why do we need to be doing their urinary output and DTRs every hour? Side effects for the magnesium sulfate, number 1. That's the main reason. Also, because it relaxes them so much, we want to make sure we're not overdosing them. And also, magnesium sulfate is excreted through the kidneys. So if they're not peeing, they're not putting the mag out, and they can get toxic very quickly. So urinary output is a very important piece of this because of the mag sulfate, because of how it's excreted. So theoretically, you could be giving somebody a pretty low dose of mag, and if the kidneys are not excreting it, then the mag level will rise and rise and rise, and if you're not doing mag levels and not assessing the reflexes, you won't realize what's going on. Okay, if they're on mag sulfate, at the dose we use in OB, complete bed rest due to the weakness. They'll be very weak. Magnesium, anybody in here been on mag sulfate? How do you feel?
I felt fine, but they told me that I could get really, really hot inside, and I couldn't get out of bed, which I tried. My legs were like noodles, so
yes.
Had to get back in bed.
Very weak.
And mine was due to like 3 times later. I was 31 weeks.
Okay. We also, and when we talk about preterm labor, we'll talk about mag again because it's used for both things. It's used for 2 different pregnancy conditions. Here it's for preeclampsia. But anybody else raise their hand? You know what? How does it make you feel? Flush skin. Yeah, hot and flush. Especially when they're given the loading dose of it and starting it, patients will feel, oh my gosh, it's so hot. Oh my gosh, you got to do something. I'm about to die. I'm so hot. And then they'll get better. But then they have to feel flu-like. Their legs feel like jelly. It is not safe for them to ambulate. They use a bedpan. They don't get up to the bedside commode. Complete bed rest for this patient. The nurse should be constantly vigilant for signs of toxicity. Signs of toxicity are sleepiness, decreased respiratory rate, the bradypnea, no reflexes or very minimal reflexes, because remember, if it's a smooth muscle relaxant, it's relaxing those muscles. The cellular excitability is going down, so your reflexes may get to the point where they're absent. If you have absent reflexes, you're on too much mag. I don't care. You never want somebody's reflexes to be absent. They might be 1 plus or decreased from mag, but we would never want them to be absent. They will need to have their mag dose adjusted. Again, if the patient's very preterm, we need to prepare them for a preterm delivery and let them know that's probably what's going to happen. Because we can't keep somebody on mag for 12 weeks. I mean, you just can't stay on mag that long, and usually the patient's condition will worsen. So again, we're going to give mag for preventing seizures, not for blood pressure. Okay, any questions about that? So what you need to know about mag sulfate therapy, because this is management, this is nursing management. So you need to know you're going to be doing mag levels every 4 to 6 hours, or about every 6 hours, and the mag level is 4 to 6. It's therapeutic. You're going to be doing blood pressure, vital signs, urinary output, deep tendon reflexes every hour. Patient's going to be on complete bed rest. You're going to be vigilant for signs of toxicity, which are rising mag levels, are going to be fatigue, sleepiness, bradypnea. Also you can see nausea and vomiting when your mag levels get high as well. So you're going to observe it for that. What happens if you give somebody too much mag sulfate? You know what happens? Anybody know what happens? What's the worst thing that happens? They stop breathing. They literally stop breathing. Smooth muscle relaxant, it just relaxes their respiratory muscles and they just stop breathing. What happens is, their respiratory depth will be okay, But there'll be 12, then it'll be 10, then it'll be 6, then it'll be 4, and then it'll stop breathing. I've seen 2 patients have a respiratory arrest from max sulfate. One of them was on an elevate. I mean, I wasn't with her, but someone sent her to ultrasound, and somebody took her. I don't know what happened, but her mag got taken off the pump somehow, and she was in ultrasound and arrested because her max sulfate got taken off the pump, which means it was running through. Yeah, she got a bolus. Yeah.
Oh my God.
Yeah. And another patient, again, not my patient, not my patient, but a patient was delivering, and this patient was on Pitocin and mag sulfate because they were inducing her labor because she was preeclamptic, and she was on mag because she was preeclamptic, so they were running both. At birth, like I told a lot of you guys, at birth, we give Pitocin in huge doses on every patient, and what do you think she opened up instead of the Pitocin?
Oh my God.
She opened up the mag.
Oh my God.
And the patient got a bolus, and so the doctor got her sewed up episiotomy, and the husband says, I don't think she's breathing. And she wasn't breathing. So we had to do code, right? Baby
I don't think she's
code, we had to look all that.
Did she survive?
Yes, all ended up well. They caught it obviously very quickly. So I can't remember, I think it's on one of these slides, but I'll go ahead and say it. There is an antidote to magnesium sulfate. Calcium gluconate. Calcium gluconate. So we always know where the calcium gluconate is if our patient's on MAC, because it will reverse the effects. Calcium gluconate. You can give it IM or IV in an emergent situation. Of course, you're going to want to give it IV. Okay. So now, what I'm going to talk about on this slide is I'm going to talk about different blood pressure medications that we might choose, because there are some incidences in which we will try to treat the patient's blood pressure. There are 4 here. Let's talk about the bottom 2 first. So if your patient's blood pressures go above 160 over 100 to 105, doctor dependent, so we don't confuse anybody for testing purposes. Let's say 160 over 105, which is the higher number. We'll say for testing purposes. But that's the range your book talks about, and that's about where we usually treat it. If it goes above that, they're on MAG, but we also want to treat their blood pressure because, again, we're worried about seizures, we're worried about the placenta, so we want to try to keep their blood pressure down. So we will give them either hydralazine or labetalol, IV, for short-term control of blood pressure. Either hydralazine or labetalol. And hydralazine is a arterial vasodilator, and labetalol is an alpha beta blocker. So, one of those 2. Now, you can give Procardia, which is a calcium channel blocker. However, most of the time these patients are on MAG, and you cannot use Procardia with mag sulfate because you can have a musculoskeletal reaction that causes paralysis.
Can you repeat that?
Yes. You can use Procardia for blood PO for blood pressure if you want. However, most of our patients are on mag sulfate. And if they're on mag sulfate, you cannot use Procardia because of a musculoskeletal reaction that occurs between those 2 drugs that can cause paralysis. So while it can be used, we rarely do because they're already on mag sulfate and we can't use it.
Is that calcium channel blockers in general?
Just Procardia, just that. For nifedipine.
What did you say the musculoskeletal reaction is?
Paralysis. And then one at the top, Aldimet, very, very old blood pressure medication. This is one we use for long-term control of blood pressure. So let's say your patient has chronic hypertension. She's had hypertension for the last 8 years. She's known about it, and she's on, I don't know, whatever she's on for her blood pressure. She gets pregnant. She can't take that medication because it can't be used in pregnancy. If we need to use a blood pressure med in pregnancy, we use Aldimet. So for your patients who are on blood pressure medicine already and need a substitute that's safe in pregnancy, Aldimet or methyl-dopa is your choice. Used for PO, long-term control for chronic hypertension. There are a few rare cases that they'll use it in preeclampsia. Not often. It's usually more likely to be used for chronic hypertension for patients who need a safe alternative for pregnancy. Methyl-dopa or Aldimet. So that's the clinical use of that. Hydralazine, labetalol are for preeclamptics whose blood pressure is so high we got to get it under control. We give it to them IV. And then Aldimet is our longer term blood pressure control for chronic hypertension if we need a different bed than what they've already been on. Everybody with me on that? Okay, now, in spite of our best efforts now, we put them on mag, we've managed them, we put them on bed rest, put them on their left side, they still seize. They have a seizure. Now they're eclamptic. Now we have one option and one option only, and that is to deliver the baby. I don't care how many weeks they are. I don't care if it's 23 weeks. We're having a baby. This becomes life and death for mom. You've got to deliver the baby this season. No ifs, ands, or buts. So first of all, they have a seizure. First thing you do, of course, is safety related to the seizure. Seizure precautions, observe them, make sure they're in the floor or in the bed, all the things you know to do for seizure, implement seizure precautions. If they're not on mag sulfate, start it, and then deliver the baby, in that order. Safety for the seizure, which, we don't usually give them Valium or Ativan unless they have multiple seizures.
That's what I'm saying. So you're actually taking the baby while they're seizing.
No, because the seizure, most times seizures usually last 2 minutes or less. So you wait till they quit seizing, watch them. Now, if they are like status epilepticus, they keep seizing, then we have to give them something. But I've never seen a patient that seizes longer than 2 minutes. So watch them, safety. They'll stop seizing typically. If they're not on mag sulfate, start it, and then deliver the baby. Now, most of the time that is going to mean a C-section because that's the fastest way to get the baby out. But it doesn't mean they have to have a C-section. For example, if the patient happened to be, if it's her third baby and she's 10 centimeters and she had a seizure, let's say, which has happened. She stopped seizing. We think we can get the baby out in 5 minutes, but she pushed it out. Let her push it out. Whatever's the fastest way to get the baby out. But 99 times out of 100, it's going to be a C-section. It's going to be your fastest way. Again, Valium or Ativan might be ordered, but typically if they stop seizing, we're just going to we're going to put them on mag, if they're not already, do a C-section. That's not always going to be something that you expect to see. So after the C-section then, the baby's born, the baby goes to the NICU, or the baby's mature enough, baby does okay, whatever we do with the baby, and then the mom will stay on mag sulfate. Just because she's had the baby doesn't mean we take her off the mag sulfate. She's still in danger of seizing. Remember I said I've seen patients seize for days after birth. So we leave them on mag sulfate, usually for 48 hours after the baby's born, most of the time. How do we know when it's time to take them off the mag sulfate? Well, remember Monday when we talked about that postpartum diuresis? That's when they're diuresing and they're moving all that fluid, mobilizing all that fluid, and they're starting to pee it out. That's when we know they're getting better. When that edema, starting to subside, and they're starting to pee 300, 400, 500 mLs an hour, that's when we'll stop the mag. So if your patient postpartum is peeing 30 mLs an hour or 40 mLs an hour, usually you've been taught that's okay. That is not okay in a postpartum patient. They should be putting out a minimum of 100 mLs an hour, and usually it's far, far, far greater. They should be putting out at least 100 mLs an hour postpartum. But when they start putting out huge amounts of urine, then they'll take them off their mag. Sometimes it takes a while for the disease to clear quickly. So as you know, we talked about this. Chronic hypertension is associated with increased risk of a placenta abruption, right? Everybody understands that, right? Because of the high blood pressure and the damage it does to the placenta, the calcification of the placenta. So abruption is what we're going to talk about next. And abruption is when the placenta blows off the uterine wall. That happens from high blood pressure. Chronic hypertension is associated with increased risk of superimposed preeclampsia, increased risk of perinatal mortality, uteroplacental insufficiency, intrauterine growth restriction, and then, of course, fetal heart rate problems, which we haven't talked about yet, but we will. Are anti-hypertensive drugs found in breast milk? Yes, they are. However, Aldomet or methyldopa or hydralazine are the choices for women needing medication for hypertension who wish to breastfeed. So these are the two drugs that are considered safe for breastfeeding. Aldomet's the one we just talked about, remember, Aldomet or methadone, that's the long-acting drug for patients who need blood pressure, like, something safe. If they've been on chronic hypertensive meds and they need something safe, then we would give them methyldopa. If they're preeclamptic and they're still having blood pressure problems after birth of the baby and they want to breastfeed, we would give them hydraulic. Okay, that is the end of preeclampsia. Do y'all have questions about that? I know it's big, I know it's a lot. Understand what's going on, understand why they have wrist reflexes, understand why they have headaches, they have epigastric pain, they start worrying about their liver. I mean, they've got to have the PRE, the proteinuria, rising blood pressure, and edema. All the other symptoms mean it's getting worse. So your basis is the three triad of things for diagnosis. And other symptoms indicate worsening disease. So if they have worsening disease and the parameters are there, then we start them on magnesium sulfate, put them in the hospital. They're on magnesium sulfate, you need to remember the management. What do we do with these patients? We do vital signs every hour. We do reflexes every hour. We do urinary output every hour. What's the therapeutic mag level? What do we want their mag level to be? 4 to 6, right? How do we assess for toxicity? I gave you the list of symptoms: bradypnea, nausea, vomiting, sleepiness, grogginess, weakness, and reflexes that become either minimal to absent. And we will need to adjust our magnesium sulfate. Okay. Any questions about any of the hypertension section? No? Let's move on then. This one's real quick. Hyperemesis gravidarum happens when patients vomit. They start vomiting in early pregnancy, and for most of the women it goes away, and they feel better and all is well. For a few patients, very few, less than 10%, I think, it continues throughout the pregnancy, and it becomes severe. They lose weight instead of gain weight, and they have electrolyte imbalance. So we believe it to be attributable to a high level of hormones. So the pregnancy usually is healthy. We usually think, okay, it's a good pregnancy, lots of hormones, but the patients are very, very ill. I've seen women that literally had to have a central line of TPN. I've seen them be up on the GYN floor with central lines of TPN because those are the only nutrients they were getting. They literally couldn't keep anything down. Their electrolytes were all whacked and just couldn't keep enough nutrients down. So why couldn't we put an NG tube down or a PEG tube? Why wouldn't that work? Yeah, it's still, when something hits their stomach, they're still going to throw up. So it doesn't, the only way that we're going to get any nutrients in them is to bypass that and do TPN. So NG tube, PEG tube wouldn't do it any good because their stomach is not tolerating anything in it. So clinical manifestations are nausea with or without frequent vomiting. Usually it's vomiting, but there are a few patients that the nausea is just so bad they can't eat. But most of the time we see vomiting, weight loss, electrolyte imbalance. I've seen women come out of pregnancy 30 pounds lighter than they were the day they got pregnant. At least, yeah. More than once. Yeah. He's 30 pounds lighter. And, they should have gained 25 at least, probably. So they probably just really lost 50 pounds of mom weight during the pregnancy. I've seen it be significant. And usually if they have it once, they're apt to have it again. Somebody mentioned to me the other day, and this is true, Kate Middleton. She has had that with multiple friends. She's skinny already. I don't know how in the world they dealt with her, but she's already been skinny. But she had it, I think, with all the pregnancies. I don't know if it was more severe with some than others, but usually when you have it more than one pregnancy. So what you just have to remember is, that we assess for weight loss, electrolyte imbalances. We assess the health of the fetus, and we may have to treat them. But if they had, what kind of acid-base imbalance would you anticipate this patient having? Frequent nausea and vomiting. So what type of acid-base balance do you think this patient would have? If they had acid-base imbalance, I should say. Acid-base imbalance. Metabolic alkalosis. Very good. Frequent vomiting, they're vomiting up all that acid, so they're going to have metabolic alkalosis. So you may have to be aware of that and then treat that. Very good. All right, hemorrhagic disorders. We're going to talk about miscarriages. We're going to talk about previa and abruption. So these are things that cause blood loss during pregnancy. So obviously these conditions we're going to talk about increase the risk for hypovolemia, anemia, preterm birth, preterm labor, and it adversely affects oxygen delivered to the fetus, of course, and fetal hypoxia. First one is miscarriage, early miscarriage. So we don't think about, or spontaneous abortion, we don't necessarily think about somebody bleeding to death from a miscarriage, but depending on the situation, it is possible. There's different types of miscarriages, which we're going to talk about. The management depends on the classification. Once a miscarriage has been diagnosed, some women will require further treatment, usually a D&C, dilation and curettage, which is dilating the cervix and removing the products of conception. And some women will pass everything and nothing is required. It depends on the patient. Now, I don't have this in my notes, so I hope I can remember this without looking at the notes here. So these are different types of miscarriages. This one is threatened. In this one, there is some bleeding. So you can see the blood coming from the cervix here. But everything's still okay up there. The baby, if the fetus is, if it's 6 weeks pregnancy or more, we can check the heartbeat with ultrasound and know the baby's okay. If it's less than 6 weeks and we can't check the heartbeat by ultrasound, what test could we do to help give us the reassurance that the pregnancy is okay? What blood test did we talk about?
Beta HCG.
Beta HCG. Yes. That if it's doubling every other day, then that would tell us that even though in the presence of bleeding, the pregnancy might be okay. If the beta is not doubling every other day, especially if it's not going out much at all, then we don't have much hope the pregnancy is going to survive. But that is a threatened spontaneous abortion. This one is inevitable. Let's see. Inevitable?
Yeah.
Inevitable. Okay. Tell me if I get it wrong. I don't know my memory here. Inevitable. So in this case, the placentas will lose, the baby is deceased, there is bleeding, and it's inevitable it's going to happen. The pregnancy is lost, but it hasn't been passed yet. Okay? So at the end, we'll talk about which one of these needs D&C. This one is an incomplete because the fetus is not here, the fetus has been passed, but there's still placental parts left, and they're still bleeding. This one is a complete, so everything came out of the patient intact. That means the fetal parts, the placenta, all the membranes, everything came out intact. This one is what we call missed abortion. In this case, in a missed abortion, the patient doesn't have any bleeding, the blood all stays on the inside. Patient just goes in usually for a normal visit. She might be 8 weeks pregnant, 9 weeks, she goes in for a visit. And there's no heartbeat, so, they look and there's no pregnancy. I mean, the fetus is deceased. And in that case, everything's still in there. That's what we call a missed abortion. She's lost the baby, but everything's still there. So, in this one is threatened, so we don't do anything. For threatened, we wait and make sure everything's okay. Threatened one, we just wait. If it's an inevitable, this patient's going to need a D&C. Baby is not, he has not survived, but there are fetal parts left inside. Same here, there are placental parts left inside. This one is incomplete, so this patient's going to need a D&C. This one's a complete, everything's out. This one does not need a D&C. This one is missed, this one's going to need a D&C. Which ones are going to need a surgical intervention? This one, this one, and this one.
What does D&C mean again?
Dilation and curettage. Dilate the cervix, and curettage basically means to scrape out the uterine part, the products of conception. A curettage is a scraping instrument. So, can you have massive hemorrhaging from a miscarriage? Yes. So, if everything's gone by placental parts, this is probably, to me, the most highest risk of hemorrhage. But it's going to continue to bleed until we get those placental parts out. Again, if it's a threatened miscarriage, there's not much we can do. We'll wait and see what happens. A lot of times we'll tell the patient to go home. We'll put them on bed rest. top, it doesn't do anything, but it makes them feel like they're doing something. But it's either gonna, happen or not. Miscarriages are gonna do what they're gonna do. Not a lot we can do to change it. Now, if we discover that the patient is having repeated miscarriage because of low progesterone levels, we talked about that the other day. We can give a progesterone, but that usually is diagnosed after the fact. Yeah.
Somebody said the other day, was talking to me about it, about someone whose baby died, and she had to go for weeks before they did the DNC.
I can't imagine why, because that increases the risk of infection dramatically. I can't think of any reason why you would do that. The baby was actually
Or
already.
maybe she had to go in labor.
Mhm. Depending on how many weeks you are, you may have to go into labor.
Yeah.
DNCs can't usually be done past about 16, sort of subjective, but 16-ish weeks, 17 weeks. After that, you have to be induced. Yes, that's possible. Now we're going to talk about patients who have repeat miscarriages. Over and over again. You got to figure out why. Sometimes it's because they have low progesterone levels, so we'll supplement in that case. Sometimes it's because they have a cervix that's called, we've always called it an incompetent cervix. Basically, it means that painless dilation happens and the fetal parts just fall out, essentially. To be quite honest. Your textbook thinks that says that is not an appropriate term because it's, I guess, derogatory to call somebody's body part incompetent. That is really what's happening is, if you have an incompetent cervix, the cervix or the door of the uterus will not stay shut. And it causes repeated miscarriage. So in patients we've diagnosed that to be a problem, we do a procedure called a cervical cerclage. Cerclage means we just put stitches in the cervix like a purse string and tie it closed to keep the baby in. And a cerclage, they're usually very effective for a patient with that specific diagnosis. Now, if they try to do it in somebody that has a different diagnosis, it may not be effective, but with a true incompetent cervix, meaning nothing's wrong with the cervix won't stay closed, when it starts to feel pressure from above, it just opens. Like a faulty door, just keeps opening. So we tie it closed.
And you keep it tied until delivery?
Until they're 37 weeks, and then they clip the suture and let them deliver. Yes.
Have you seen that procedure done?
Oh, many times.
Do they numb the cervix?
They usually do an epidural. Yeah. They usually do an epidural anesthesia, and then they'll go in and vaginally, and they'll just put stitches all the way around it, and then leave them in the hospital for the day or for the evening, send them home, and usually they do really well. Let's say the patient did, for whatever reason, go into labor at home. What do you think will start happening? She's going into labor, and now she's got stitches in her cervix. What do you think will start happening? She'll start bleeding. So we tell patients instructions, if you start bleeding, you need to come in and be evaluated. We don't want those stitches to rip out. So any kind of bleeding or cramping, they need to come in and be evaluated. We wouldn't want their uterus to rupture because we tie it closed here. You know what I mean? We artificially close it, and then they start contracting, and their uterus ruptures. So we watch them very closely. But I've seen them come in at 37 weeks many times. We clip them, see what happens, and if they truly had an incompetent cervix, they'll go into labor right then. It's very effective. I've got a picture here of how they take the suture, and that's the opening of the cervix. That's the door, and they just put the suture all the way around it and tie it closed. Very well. Okay. The next thing we're going to talk about briefly, and I think we talked about this already a little bit, is an ectopic pregnancy, an ectopic or tubal pregnancy. You can bleed to death very quickly from an ectopic pregnancy if we don't get medical care, especially if it ruptures. So remember, an ectopic pregnancy is when that egg and sperm have united, but it doesn't move down into the uterus and implant like it's supposed to, right? It doesn't go where it's supposed to go, and it stays in the fallopian tube. So the cells are continuing to grow, and it's getting bigger and bigger, and eventually what's it going to do to that tube? The tube's going to rupture. It's going to get far too big for the tube. It's going to rupture the tube. So if you have a ectopic, if it's not ruptured yet, then you're going to do well typically, and they may be able to save the tube if it hasn't ruptured yet. They may be able to go in and remove the cells with the pregnancy without damaging the tube. Or sometimes they'll even give you methotrexate, which is a chemo drug that will cause you to lose the pregnancy and prevent damage to the tube, save the tube. If the tube has ruptured, you will bleed profusely, and the patient will present as like someone with a belly full of blood. They'll be hypovolemic, they'll have massive distension of their abdomen, they won't be able to touch their belly, their blood pressure will be low, pulse will be high, for this early pregnancy. And they'll have to go in and stop the bleeding, and they'll lose their whole fallopian tube. So if you lose your fallopian tube, what does that do to your reproductive capability? Cuts it in half. Because now you can't get pregnant on that side anymore. You've lost the tube, right? So if a patient's pregnant, or maybe they don't even know they're pregnant yet, and having left side or the right side of pain that is severe, their belly's getting distended, they need to hightail it to the ER. Make sure they don't have an ectopic pregnancy. Because again, if the tube ruptures, it's life-threatening. So we're worried about hemorrhage.
I don't know much about like egg harvesting and stuff, but if the tube does rupture, would it still be possible to harvest the eggs if they have them left in that?
Yeah, yes, because they can take them, they can get them from right, if they can get them from right outside the ovary, they can still harvest. Yeah, so if you're going to have in vitro or something, they can still do that.
That was my wonder. I just didn't know if like you lose that tube.
No, you wouldn't lose that, because I don't think, and I probably need to look it up, but I'm pretty sure I'm right, that you can still harvest the eggs, but you just couldn't get pregnant naturally on that side.
If not, those eggs would just be enveloped by the body, right?
Reabsorbed. Yeah, so if you lose that tube, what happens every month when you release an egg? It's so tiny, it just gets reabsorbed in the body. This is possible sites of extrauterine pregnancy. So any pregnancy outside the uterus is incompatible with life, but here's where you usually see what we call it ectopic because it means in the tube. But you can have pregnancies that develop anywhere. Usually the baby, it stops growing at some point and it's incompatible with life.
What did you say it was sites
Of extrauterine pregnancy, meaning a pregnancy that occurs outside the uterus. It could be even in the abdomen, but again, usually they just die off.
How does it get in the abdomen?
Well, that's a good question. I'm not sure I can tell you that. Unless there's a piece of fallopian tube. I don't know. I don't know. I'm speculating. I'm not going to speculate. I don't even know.
That's just odd.
I saw one on a TV show. There was a TV show a year or two ago about this pregnancy. They were like 8 months pregnant. It was out in the abdomen. So I'm like, that cannot happen. But it was TV. On TV, anything can happen. So we talked about this already. Ectopic. Medical. We can give the patient methotrexate, which will destroy the embryo in some cases, and that will prevent having to lose the tube if the tube hasn't ruptured yet. Salpingectomy is removal of the fallopian tube, removal of the affected tube, as well as the products of conception. Okay, now the two biggies that we've got to talk about, and I want to get these in today, are placenta previa and placenta abruption. I remember learning about these in nursing school myself and trying to keep them straight. Of course, now I know them well, but I remember having trouble keeping them straight. The biggest problem you're going to have is which one is which. So we're going to talk about placenta previa first. Placenta previa happens when the placenta is implanted in the wrong spot in the uterus. So in the uterus, as the placenta grows, as the uterus grows, the placenta proportionately takes up less space, but it needs to be in a certain area because we want the baby to be able to get out. So I'm a terrible drawer. So this is the uterus and this is the cervix. This is the cervix right here. This is the uterus. The baby's inside here. The placenta should be attached either up here, or it can be attached over there, or it can be attached up there, or even right there. Any of those places could be placenta. Now I'm gonna draw like a stick figure baby here, so you can laugh if you want, but I can't draw a baby. But anyway, here's our umbilical cord from the baby, and if it's going to the placenta there, all's well. Or here, or here. But what if, on the other hand, the placenta is here? Now what's the problem with that? If the placenta, this is the cervix, this is the door, this is where the baby's coming out, and the placenta's right there. The baby has to get through the placenta to get out, right? So it's going to kill the mom and kill the baby if the baby starts coming down through there, where that placenta is, right over top of the cervix. Very, very dangerous condition. You can have a complete placenta previa, which this is, it's completely covering it. Or I can have a partial or marginal placenta previa, and the placenta is just right here on this side of it. Or I can just have a low-lying one where it can maybe just be right on the side there. So it can be complete, it can be marginal or partial, it can be low-lying. So previa, I always think of it as previa, the placenta is kind of previous to the baby. For the baby. Placenta is ahead of the baby, the bottom line. I've got some better pictures here. So again, this is the cervix right here. This is the cervix. That's the door. Very slightly open. The cervix is always open a tiny bit. And then the placenta is implanted right here. And it should be way up there somewhere. Here's the cord, and the baby's up here. So this one's a complete previa. This one is a marginal or partial or low-lying one. So it's just right at the edge, but you still see some bleeding there. So it's a dangerous condition that really is just about where the placenta implants on the uterine wall. Now, in early pregnancy, you can have a placenta previa, and then as the uterus grows, it can move up as the uterus grows. So it's not uncommon to have a previa in early pregnancy, and then it goes away as the uterus gets bigger and bigger. So if you're diagnosed at 18 weeks with a previa, it might possibly go away. Usually, if it hasn't gone away by the beginning of the third trimester, it's not going away. So, who's at risk for placenta previa? Someone who's had a previous C-section, or any kind of previous uterine surgery is at risk. But think about it. If you've had a C-section or previous uterine surgery, you've got scar tissue there, right? So the placenta tends to implant where the scar tissue is and then not be able to move. Scar tissue kind of makes it adhere to that area. So risk factor are previous C-sections, prior uterine surgeries. What do we see? How do we diagnose it? Well, if we see it on it's diagnosed by ultrasound. However, the classical clinical symptom that the patient has, hallmark symptom, I have all kinds of letters there. Painless, bright red, vaginal bleeding. So the patient has, there's no nerve endings in the placenta, so the patient might not feel anything. Painless, bright red, vaginal bleeding. So that's really important to remember that specific symptom. Now, you're not going to have pain. It's going to be bright red blood, no nerve endings. Something else that can develop as a result of a placenta previa is something called an accreta, A-C-C-R-E-T-A there. When an accreta happens, here's what happens. So the patient, let's say, had previous C-section, previous uterine surgery. The placenta implanted low in that area because of the scar tissue there, and then it couldn't move because of the scar tissue. So then what happens at birth, it pulls off, and I hate to be graphic, but like a scab pulls off of a wound, just kind of pulls off the surface. That's what happens at birth. Placenta just pulls off. But what happens if the placenta grows roots into that uterine wall? That's an accreta. When the placenta literally grows into the uterine wall. So when it tries to separate, it literally pulls pieces of the uterus off of it. If we try to manually separate it, like let's say in a C-section, we'll pull the uterus apart. That's going to cause the patient to bleed to death. So placenta accreta is a very, very serious, very, very life-threatening occurrence that only has one cure. What do you think we might have to do? If we can't get the placenta off, what are we going to have to do? Hysterectomy. Take the whole uterus out. There's no way to get the placenta off. You certainly can't leave it there.
What causes that for it to bleed?
Usually previous surgery and scar tissue. So what happens is, when the scar tissue is there in the uterus, it's rough, and instead of smooth, it's rough, and it causes that placental tissue just to grow into the uterine wall from scarring. So if we diagnose an accreta by ultrasound, then we usually take the patient to surgery anticipating a hysterectomy, even if it's their first baby, because you just can't get it off. You can't leave it in. It has to come out. And the only thing we can do is take the whole uterus out. So we rarely, if ever, except in this case, we don't do C-section/hysterectomy because of how vascular everything is in the pelvis, because of how much blood you lose when you try to do a hysterectomy. But this is an exception to the rule. Because if we don't, the patient will die. So if the patient needs a hysterectomy, with this exception, we don't do it at birth because, again, it's so vascular there that the blood loss is just unbelievable. But in this case, we don't have any choice. I've seen some patients come as close to death as you can get with a placenta accreta. I have to say, because of good management, I've never seen one die. And I think it's just because of good management. I'm sure in other little hospitals, places they have. But if you know it ahead of time and you're prepared for hysterectomy, usually, you can manage it. So, you just need to remember what an accreta is and what the treatment is. And why they would get an accreta? Usually because of scar tissue in the uterus that keeps the placenta from being able to move. Okay. So, if you have a placenta previa, you're also, I didn't mean to do that. I think I hit my hand on there. How far back I went? There we go. Another risk as a result of placenta previa, we usually see fetal malpresentation, which means breech or transverse or some crazy presentation that's not head first. Why do you think that is? Because we're usually seeing a lot of these cases early in pregnancy, like 28 weeks, 30 weeks. So the babies haven't had a chance to get head down yet. So a lot of times we have to deliver them early, and the babies are also breech or whatever position. So also that would predispose us to have to do a C-section as well. If you have a placenta previa, all right, so let me back up a minute. So diagnosis is a abdominal ultrasound. That's how we diagnose previa. But the classic clinical symptom is painless, bright red vaginal bleeding. So let's say the patient is diagnosed at 18 weeks with a placenta previa. It doesn't move. It stays there. And at 28 weeks, it's still there. She comes in the hospital again because she started bleeding. And so now what we're going to do is we're going to admit her to the hospital, put her on bed rest, because anything they do causes bleeding. Any activity, every little thing will bounce the placenta and cause it to bleed. So she may end up in the hospital until the baby's born, possibly. Management, C-section birth is a must with a placenta previa. No other way around it. The baby would have to go through the placenta to get out. That's impossible without killing mom, killing baby. So C-section is an absolute. For once diagnosis is made until the baby's born, nothing for vagina. That means no intercourse, no exams, nothing.
Does it depend on what kind of previa?
Yeah, if it's just a low line, they may not put those restrictions on you. But
Right,
if it's
it said something if it's located between 1 mm and 20 mm from the internal cervical, 60% of women may choose to attempt vaginal birth.
well, that would be a marginal or low line. I'm sorry, low line. If it's a low line, yes, yeah,
You're talking
that would be,
obviously complete.
I'm talking about complete.
How about
Partial, probably. Most likely with a partial, they're not going to mess with it. A marginal or low line, maybe you might attempt a vaginal delivery, but with a partial or complete, low line means it's down low, but it's kind of at the side. And what we worry about is the baby brushing it on its way out, maybe. But with a partial or complete, it's partially obstructing the cervix to the point where it's going to damage the placenta as the baby comes through. So that is a big risk of hemorrhage. So for partial or complete, then nothing for vagina. That means no intercourse. It also means no sexual activity because avoid contractions at all costs. Most sexual activity causes uterine contractions. No exams, no vaginal exams. So if I have a patient, I'm working in triage. And I have a patient, don't know her, don't know anything about her. She comes in, she's 28 weeks, and she has vaginal bleeding. I don't just go in and start checking her. I start asking, if you had prenatal care, have you ever been told you had a placenta previa? I'm not going to check her until I've got some history and know what's going on because I'm not going to stick my fingers in a placenta. And that would be a bad day. So, until you know or have reassurance that when a patient's bleeding, you don't ever examine them until you have reassurance that they do not have a placenta previa. And you would get that by ultrasound. And a lot of times these patients, it's like a waiting game. How far can we get them before they bleed so much we got to get them delivered? So we just wait, they bleed. They have bleeding episodes, they stop, they start, they stop, they start. Just because it's so irritable in that lower part of the uterus that the doctor, really kind of a doctor's worst nightmare to have a patient with a complete previa because you're constantly worried about, is this going to be the big one? Is this will be the big bleed, where they hemorrhage to death before I can get them to the OR. So I've seen patients sit on labor and delivery for 6, 7, 8, 10 weeks with complete previous. And because they bleed a lot, they have a lot of bleeding episodes, the doctor got tired of, worried about them and says, okay, you're going to the hospital. Now, if they bleed enough, we'll do a C-section. If they just bleed a little bit, we'll just continue to watch them as long as the baby looks okay. So this patient may end up in the hospital sitting, waiting. Hopefully she'll get far enough along as the baby does okay. But placenta previas are like a ticking time bomb. They have a placenta that's in the way. If the contractions or labor starts, then you're really in trouble. This is a picture of a normal placenta up here. Here's a placenta, a marginal one. See how even this marginal when it comes to the edge right there. So, per your question, Stacy, it depends on how many millimeters it is from the cervical os. And then this was a complete preview where the placenta is completely covering that opening. So normal, marginal, and complete. Okay, that's all about placenta previa. So the big things to remember about placenta previa, what it is. Placenta is coming ahead of the baby. It's covering the cervix. And blood loss is what you're worried about. Your symptoms, painless, bright red, vaginal bleeding. Your treatment, if it's a complete or even partial, nothing for vagina for the duration of the pregnancy. Watch for bleeding incidences. They will have a C-section for absolute sure. And they're at increased risk because they have a placenta previa of having something called a placenta accreta, where the uterus literally the placenta usually grows into the uterine wall. Once it grows in there, it cannot be separated. The only way to get that, when you can't separate, you have to take the whole uterus out. So, placenta accreta is a complication that is common as a result of the placenta previa.
Have you seen those?
Oh yeah.
So,
I'm thinking maybe I've seen dozens. So maybe a dozen over the years. And I think every one of them had hysterectomy. I don't think I've seen any that did not. And a lot of times they know that ahead of time, so they'll schedule a C-section / hysterectomy. And usually they bleed so much during the case even until they get the uterus out. They get blood, they end up in ICU because it's so bloody, just trying to get the whole thing out.
Is that something that's more like it is noticed during an ultrasound? Like, do they
Yes. On a routine ultrasound, they always look for that. Yeah. So, someone gets early prenatal care, we know well if they've got a placenta previa. It's, the ones who don't get early prenatal care are the ones who come in who may not know.
So if the placenta moves before the end of the pregnancy, then was it a partial? What was it?
It can be a complete and still move. If it's real early. Remember that the uterus at 15 weeks may just be this big. As it gets bigger, placenta may, as the tissue gets big, it just may pull up with it. So even a complete previa can turn into a, low lying or even move up there. But the most likely ones to move are a marginal or a low lying. Those are the most likely to move. I've seen complete ones move as well. So if it's 15 or 18 weeks and on ultrasound we see a previa, it's not the end of the world. We say, let's see what happens in the next month or so. We'll know in 6 weeks or so. We'll know if it's moving or not. If it's not moving, then you're in for a long pregnancy. Because again, these patients with previous have bleeding episodes. They're bleeding any little thing, any little contraction, anything starts bleeding. Because when you contract, that uterus contracts, it irritates that cervix and that placenta, and it causes it to bleed. Whether that placenta being down there. So they have all kinds of bleeding episodes usually. We don't want to deliver a baby at 27, 28, 29 weeks if we can keep from it. So a lot of times they'll just park them in the hospital and just, that way at least they're right there. We can do a C-section.
I was going to say, if it's a ticking time bomb, I don't think I'd want to be waiting at home.
No, I know. I have a friend, my husband's a State Farm agent, and this person is also a State Farm agent, and she had a complete previa, and she had several instances of bleeding, but she was still at home, and she lived in Hurricane of all places, what it's like to get here from Hurricane. So and this was the last straw, she had a bleeding episode, her husband was trying to get her here, and he was coming up to where State is, to the Dunbar exit, coming up through there, and the traffic was backed up. He was driving through the median, he was over the other lane, he was on the exit, I mean, he was everywhere trying to get here. He was telling us about all the places he was all over the road trying to get here. And she ended up, she didn't even have a Creta, she just had a Previa, but she lost so much blood, they ended up having to do a hysterectomy after her C-section, even before they could get the bleeding stopped. And
How many weeks was she?
I don't think she ended up being maybe only 6 weeks early, so that wasn't bad. But, we don't want to deliver somebody at 28 weeks if we can keep from it. So if they stop bleeding, we'll park them in the hospital and say, okay, at least you're here. We can get 2 more weeks to 30 weeks. When a baby's at that stage, every day is huge in terms of their development and how they'll do when they are born. So if we can get them to 30 weeks, great. Usually anything after 30 weeks has a really good outcome. But before 30 weeks, we try our best to keep the baby in if we can. So this is the patient who will be parked at the hospital setting for weeks and weeks on end. So.
Have the doctor park. I would say.
Well, they usually live pretty close by necessity. Okay, the other thing now, and I don't want you to get them mixed up. That's the problem everybody has, getting them mixed up, is a placenta abruption, or abruptio, or abruption. I just call it abruption. Abruptio placenta. This is different. This is when that placenta comes off the uterine wall before birth. So in this case, the placenta, something causes it to come either partially or completely to separate early. When's it supposed to separate? After the baby's out, right? After the baby's out, the hormones cutting the cord tells the brain to cause the placenta to pull loose, and the placenta pulls loose and exits the body. That's what's supposed to happen. If it comes off before the baby's born, the baby's just lost its lifeline. It's like essentially cutting off the baby's circulation 100%. Somebody, putting something over your hand and mouth, no more breathing, no more oxygen. So what would cause a premature separation of the placenta or an abruption? It can be spontaneous. There are events that we cannot predict, so it can be spontaneous. Drug-induced is caused usually from amphetamines. We talked about that this morning. Your cocaine, your methamphetamine. In my experience, is that it's far often caused by cocaine than any other drug I've ever seen. I've seen multiple cocaine-induced abruptions. Some where we lost the baby, a couple where we lost mom and baby. Violence of somebody kicks you in the belly. I've seen a lot of partner abuse that where we've had abruptions from blows to the belly. I saw one very tragic incident where a toddler kicked his mom in the belly, not intentionally, but kids will lay and kick and thrash, kick the mom in the belly and cause an abruption. Not intentional, just the kid playing rough and kicking. Seen several from car accidents. The mom comes in contact with the steering wheel and trauma from the steering wheel. It can happen in late pregnancy or early pregnancy. An abruption can happen as early as 10 weeks. An abruption can happen. Now, obviously, if an abruption happens at 10 weeks, it causes a miscarriage or spontaneous abortion. That is not a fetal, that early, there's nothing we can do. It's just a miscarriage. Classifications or grades. Grades 1, 2, and 3, mild, moderate, or severe. And it really has to do with how much of the placenta comes off, how much comes loose. If just a little top piece comes loose like that, maybe this much of it, the rest of it's all there, still intact, maybe everything will be okay. Maybe there'll be some bleeding, but the baby does okay. So we've seen some partial abruptions that we just watched and everything turned out okay. That's possible. What you see as far as clinical manifestations, usually you see bleeding, but there are incidences depending on where the placenta is that you might not. But typically you see bleeding, and it's more going to be not bright red. It's going to be dark, old blood, because usually it takes it a while to exit the body. It's not right there at the cervix like a previa is. So it's dark red blood or old-looking blood, and most frequently you see with abruption you feel abdominal pain, especially if it's violence, like a kick to the. I also saw a patient got kicked by a horse once, had an eruption from getting kicked off behind a horse and getting kicked in the belly. So a blow to the abdomen will cause pain and will cause literally what we call a tetanic contraction. It means a contraction that starts and doesn't stop. It just contracts to the point where the uterus, the placenta pulls off the uterine wall. And so you see bleeding and pain, abdominal pain, typically with abruption. That's what separates it from a previa. No pain with previa and not dark blood, but bright red blood. Abruption, darker blood, and usually we associate it with pain. So here's a partial separation. I can't reach up there, but you see right there where it's come loose just a wee little bit right there. That is a partial or concealed hemorrhage, and there's no way for that blood to get out. It's trapped right there. So that patient is not going to bleed. The blood is trapped right in here. So it's a concealed partial abruption. We may never even know until birth. We may not even know it happened. So if the baby does okay, then there's problems with the baby's heartbeat. That's small enough that there's enough placenta left that likely the rest of it will serve the baby. This one is partial. The bottom part pulled loose, but you see where the blood, in this case, can exit the body, so this patient will have bleeding. All this top is still connected. The bottom part is pulled loose, but this patient's going to bleed. This one is complete, but it's concealed. It's pulled loose way up here, and this little, bottom piece is all that's left, and it's keeping, so this patient's not going to bleed. So there are cases where you don't see blood. I will say that's unusual. Usually you see some blood. 9 times out of 10, I would say you see bleeding, and it's dark bleeding. If you have a complete hemorrhage, you usually don't have that little piece left. I wouldn't even call that complete, actually. And the patient, again, usually will feel abdominal pain. And it's not like contractions, it's like constant. Contractions will come and go, and a patient will be able to tell that's a contraction, but if she has constant abdominal pain, even without bleeding, we need to be suspicious of an abruption because it could be a concealed one. And then progression of a placental abruption, you can see the placenta starting to pull apart here. You see the color of the baby, all the blood there, pooling there, all the tons of blood here now. Baby in this, blue, now the baby's blue down here because there's no blood supply for the baby. So you can see we're starting to pull loose here. There's a little bit of blood, more blood, and now the whole belly's full of blood. Mom's belly's full of blood. And the patient will continue to bleed until mom and baby both bleed to death if we don't get this baby out quickly. So if you have a complete abruption or even a large partial abruption, it's going to require an emergency C-section. Again, this is not what we can wait on to see what happens. We've got to get the baby out because the baby has no blood supply. And once that placenta pulls off the uterine wall and the baby's still inside, the uterus doesn't know that the placenta is not there, so it just keeps sending blood out. So the mom's hemorrhaging. It's just like an open wound that keeps pouring blood through those maternal uterine arteries. So every bit of blood in the mom's body will literally end up in her abdomen if we don't do something quickly. That's why it can be fatal for mom and baby. So the outcome depends on the degree of abruption and how fast we get care for them. If it's third trimester, of course, we want to look at fetal monitoring and see if the baby's okay. So if the mom comes in and the baby's already not with us, then we can stop a minute if she's not bleeding to death and kind of evaluate the situation. If the baby is, still viable and still alive, then we need to do an emergency C-section and get the baby out. So we gotta. So for example, I think of one example I know where someone I know that I sort of knew from my community got hit, punched, kicked, I don't know which, by her boyfriend. And she waited I don't know how many hours she waited, but she waited and the pain got so bad, she finally came in. She was like 28 weeks. As soon as she got there, they did an emergency C-section because she was bleeding. The baby was, the heart rate was, extremely low in the baby. They took her, they did an emergency C-section. They were able to resuscitate the baby. That child is an adult now and doesn't have any quality of life at all. I mean, it's not nonverbal, just a lot of, hypoxia, anoxia, just basically get fast, just doesn't have any function at all. And it just all came from blood loss and lack of oxygen. And mom's okay, but now she has as it turned out, I think her mom ended up raising that child, but that all came from a trauma. If the baby's deceased, then we may have time to evaluate what do we need to do. Do we need to do a C-section now? Can we wait to stabilize the mom? What can we do? So we look and see if the baby's okay or not, and then make a decision on how fast we have to act. Any questions about that? I know that's really complicated. I'm texting Kenny, sent me a message. All right. We'll go ahead and, if you're okay, I'm going to keep going. Just so, because I'm going to let you go at 15 till. All right. So, we'll talk today about preeclampsia, blood pressure issues. We've talked about miscarriage. We talked about placenta previa and placenta abruption. So now we're going to just talk a little bit about the placenta. We talked about it some already. I know in the recording that I did, I talked to you about the functions of the placenta. Now let's talk about some placental abnormalities that may occur. Normally you have two sides of the placenta. Shiny Schultz, dirty Duncan. I don't know why they call it that, but that's what they call it when I was in nursing school too. The shiny side is the baby side. So if I'm the baby in utero and I'm attached to this umbilical cord and I turn around and look at the placenta, that's what I see. Just because the back side is attached to the mom's uterus, right? So you see where all these vessels go out through here? That is a good-looking, healthy placenta. If it has calcifications, it has big white lumps on it. But this one looks really good. This is the back side. This is what's attached to the uterine wall. This is the dirty Duncan side, maternal side. So this is all attached to the uterine wall. This membrane is kind of pulled around, and the baby's inside of the membrane, full of amniotic fluid, and then that is what the baby sees. So that's normally what you would see in utero. Now, if you have something abnormal called a velamentous insertion of the cord, it's not a common anomaly. I've only seen a couple. I had a student a couple semesters ago that texted me like at 10 o'clock at night and said, she wasn't a student. She was a new grad who was working with labor and delivery. She'd been my student. She said, I have a velamentous insertion of the cord. What do I need to do? I said, you need to ask your charge nurse because I'm not there. I can't see what's going on. So velamentous insertion of the cord is when the cord is inserted in the wrong place. I'll show you what it looks like in just a minute. It's associated with placenta previa, associated with twins and triplets. The cords in this place, in this situation, the cord vessels are in the wrong spot. So I'll show you what this means in just a minute. So what we're in danger of is losing a baby. So what happens is, see all these vessels out here in these membranes? These should not be here. Vessels should only be on the placenta. Blood vessels are only supposed to be at the placenta. If blood vessels come out here into these membranes and the baby's wrapped in these membranes, what happens if the water breaks the membrane? When your water breaks, it breaks right here. What happens if the doctor comes to break your water and he snags it with that little hook and he hooks right there? Hemorrhage, massive hemorrhage. So anytime you have a patient when their water breaks and all you see is blood, just frank blood, you would suspect this. You might see it on ultrasound. That's how they saw it on this patient. They saw it on ultrasound and admitted her labor and delivery for not knowing what else to do. And there's really nothing else you can do. There's nothing you can do. It's just hope that it does. Hope that the membrane doesn't rupture or the doctor doesn't break the water in that area where that vessel is. So a velamentous insertion of the cord is when you actually have membranes that come out into you have vessels that come out to the membrane. So as far as nursing interventions, it can be diagnosed by ultrasound, but not always. Like I said, as far as interventions, if you are caring for a patient and her water breaks and you see just frank blood, not fluid tinged with blood, but I mean just blood, you would suspect that. And they would probably have to do an emergency C-section. Just probably not even know what's going on, just knowing that the patient was hemorrhaging and figuring it out later. And this is another example. This is a different velamentous insertion of the cord where you see the cord comes right here, and the cord is supposed to come into the placenta. But the cord here is attached to the membranes, and then there's a communication via vessel to the placenta. So that is another velamentous insertion of the cord. So here's the umbilical cord over here, and the only way it communicates with the placenta is through these vessels. So this should be on on that, not in here. So that's an abnormal finding. Just during development of the placenta, sometimes things happen. And then in the subcenterior placenta, it's divided into 2 lobes, basically. So it's one placenta, but it's got like a baby attached to it or something. That's the way I think of it. It's a placenta with a baby. So there's vessels that communicate, and you may not see this till after birth, and it may cause 0 problem. But again, we're worried about the vessels, or the blood vessels in these membranes and them getting damaged or torn open.
And they don't know what causes that?
Just during, just like any other, a lot of other, it's
Would
an
it be
anomaly.
like a family history, maybe?
I don't know, maybe, but the only thing I can think of is just, what causes any anomaly that we don't have an explanation for. Maybe it's drug induced, who knows, we don't really know, Well, those things, if it's the incidence is so low, it's hard to make an association. Okay, and then there's another one called Battledore, and that again is a cord abnormality. I think I have a picture of that one. And that is, again, when the umbilical cord doesn't come in directly, there's not vessels between it, but the cord should come directly on the surface of the placenta, not coming into the end. So it's just a similar situation, different than that. So, really, I'm not going to ask you specific names. I might ask you about developmental insertion of the cord, because that's the one you're most likely to see. But if you see that, all you need to know is that you associate it with bleeding, you associate it with the breaking in the water, and you need to act accordingly to see blood and deliver the baby and ask questions later. Or do a C-section if you have to. Okay, so we've got 15 minutes. So I'm going to go ahead and talk a little bit about some other clotting disorders in pregnancy. These are much more lower in priority than what we've already talked about. DIC. Have you all learned about DIC yet? No. Yes? No? Yes.
A little bit.
Disseminated intravascular coagulation. It can be pregnancy related, but it doesn't have to be. It can be called gram-negative sepsis, stroke, other things. But we also see it in pregnancy. So it's a pathologic form of clotting where you have clotting and bleeding in the same body. Like you have bleeding out in the periphery and clotting centrally. So there's 2 different things going on in the body at the same time. If it happens in pregnancy, it's triggered usually by severe preeclampsia and HELLP syndrome. And when we see it in pregnancy. But it can happen, again, outside of pregnancy as well. So it's very hard to manage because, you're bleeding and clotting at the same time. So usually patients with DIC, they're undelivered, we have to get them delivered, and then we have to try to treat that. That patient's going to be in ICU on invasive monitoring and on vent. And next thing after DIC is multisystem organ failure. So it's extremely life-threatening. But just remember with pregnancy, what triggers it, which is severe preeclampsia, usually HELLP syndrome, or maybe postpartum hemorrhage, worst case scenario. And that's usually postpartum hemorrhage is not identified early. It can lead to DIC.
And you said the end result could be multiple organ failure?
Yeah, multisystem organ failure. Once you get DIC, that's the next step is multisystem organ failure. So urinary tract infections in pregnancy are significant. I know we think of them as a mild, not important thing. In pregnancy, they're important for a couple of different reasons. UTIs are a very common cause of preterm labor. It can put a patient into preterm labor because if you start having bladder spasms, a lot of times that will lead to uterine irritability and subsequent uterine contractions. So think of UTIs as leading to preterm labor. So we very aggressively treat UTIs in pregnancy. So if they just have bacteria in your symptoms, we still treat them. When a patient comes in, if they have any symptoms at all, we give them a whole liter of fluid and see if we can clear that out, treat with antibiotics, and help prevent preterm labor. Because UTIs are definitely associated with preterm labor. We also worry if a patient gets a UTI that they could end up with pyelonephritis, which is when the bacteria extends to the kidneys and their kidneys become infected. And if they get pyelonephritis, they're going to need to be hospitalized and given IV antibiotics. They'll have a very high fever, and then we worry about urosepsis. So pregnant women with sepsis are not a thing you want to see. You know, it's hard to deal with sepsis anyways, frequently even worse because you're limited to what you can give her. So we want to avoid sepsis at all costs. So for UTIs, treat them aggressively because of the risk of preterm labor, and watch for signs of pyelonephritis. Okay, what about trauma during pregnancy? So, like a car wreck or any kind of traumatic event that may happen. So, anytime we think of trauma, I think of abruption. You know, is the patient going to erupt? Did she have a blow to the abdomen? Is she going to have an abruption? That's the first thing that comes to my mind. But what we want to think of, how far along in the pregnancy is she? Remember the car wreck patient I told you about the other day that had the guardrail went up through her hip? She was only like 8 weeks pregnant, so what could we do? Nothing. All we could do was make sure she didn't hemorrhage to death and she had a miscarriage. Other than that, not a thing we could do for that baby. Now, if she's 32 weeks, that's a different story. We have a viable baby, and we have 2 patients we have to look out for and figure out what's going on. So length of gestation is going to be key in determining, if it's the first or early second trimester pregnancy, we just don't worry about baby, we worry about mom, and then wait and see what happens. If it's a late second and third trimester pregnancy, then of course, we worry about both because the baby is viable. Type and severity of the trauma, degree of disruption of uterine fetal physiologic features, as in where's the injury? Was she shot in the belly with a gun? Was she stabbed in the belly? Or did she, have her foot cut off? What's the relationship to the uterus? Fetal survival is dependent on maternal survival. Obviously, with some very, very rare exceptions, unless we take care of our mom, we're not going to have a baby. So taking care of the mom is prima. There's one exception to that, which we'll talk about in just a minute. The length of, obviously, like I said, the length of gestation is key in odds of fetal survival. If it's an early pregnancy, you're likely to lose the pregnancy because of the anoxia to the uterus that happens as a result of trauma. If it's a later pregnancy, we may be able to save the baby, again, depending on what's going on. What kind of trauma it is, but we treat the mom like we would, treat any other patient, with the exception of remember, if they have trauma and they're hypovolemic, we're not going to look at our blood pressure first, we're going to look at our pulse. How is our patient affected? How's her heart rate affected? Is she hypovolemic? But other than that, we're going to treat her just about like any other patient in terms of trying to save her life. We're going to put her on her left side, remember, if she's in mid-second trimester on, we're going to position them on their left side. Even if they've got broken body parts, even if we're worried about their back, we can still put a little blanket tilt under the hip so that they're off their back. So you will notice that they, even in a trauma, they will always do a side tilt. Pregnancy causes decreased tolerance for hypoxia and apnea. And again, remember that the uterus is not a vital organ, so blood that gets shown away from the uterus when the mom needs oxygen, it goes to mom. So your babies can be very hypoxic. We already talked about circulating blood volume is increased, and the patient is disproportionately anemic anyway because of the amount of hemoglobin. So they are at risk of significant hypoxia related to blood loss very quickly. And remember, tachycardia is a better indicator of hypovolemia than blood pressure in pregnancy. You guys know that. So, first thing, patient has in a car wreck, whatever the case may be, ABCs, just like any other patient. ABCs: airway, breathing, circulation. Secondary circling, what other injuries may they have? How pregnant is she? If once we get to the hospital, they start assessing other injuries. If she's far enough along, we can do fetal monitoring. We'll monitor her. Usually, if the baby's doing okay, mom's probably okay too, because baby is, again, may have been oxygen deprived because of that shunting of blood away from the uterus. Can you do X-rays on patients who are pregnant? After the first trimester, it's typically A-OK. In the first trimester, you just have to, again, risk-benefit. If she's got 2 broken legs and a broken pelvis, you're going to have to do some X-rays. They'll do a lead shield, but you may have to do X-rays. Now, the other exception that I told you all the other day, the paraborn cesarean delivery, I said we would talk about, usually if the mom's, with a few exceptions, saving the mom means saving the baby. The one exception to that is, and I've seen this happen one time, what if the mom is clinically dead and she's full term, can we try to save the baby? You've probably read cases about this. ethical, you've seen it on the news. And, there are cases that where the mom was, called brain dead or whatever you want to call it, that they could do a C-section to save the baby if the baby's farther along. And that is a possibility. Usually when you do that, pretty much steal the mom's faith that you lose the mom. Now, so you have to kind of look at the situation with mom. Is it, can we possibly save her? Are we going to lose her? She's brain dead. Although you're going to lose her already. But you can hurry and deliver the baby and get the baby out. But remember, if you do, you're probably going to lose the mom because of surgery and blood loss and all those things. So that's what we call perimortem cesarean delivery. So there's a lot of ethical implications with that. And I'm not going to say what you should or should not do. The other situation is, should we keep the mom alive so the baby will grow? You probably heard cases like that where, patient's been in an accident, and you say, can you keep the mom alive until the baby's far enough along that we can deliver the baby? Usually that doesn't work because of all the meds and things you have to do to keep the mom alive. That usually ends up being toxic to the baby. So that usually does not work. But I have seen one case where, I can't remember how many years ago it was, a little 15, 16-year-old girl got shot in the belly over on the west side or somewhere. And they took her into the general, and she wasn't going to survive, and they did a perimortem C-section with the baby. The baby did die, but she did die. So they made a very quick decision that they thought they could save the baby, but they didn't think they could save the mom. So they pretty much sealed the mom's fate, by doing a C-section, that they were going to end up losing her, and they did. But the baby survived. So again, that's got a whole pile of ethical implications. And it's going to come down to the surgeon and the family and what decision that they deem to make is best for them. So we are going to stop right there. I had asked a couple. Ken had asked me to ask a couple people to go to a meeting. Some consultants here